Okay, I'm here today to talk to you about narcolepsy and to focus on current and emerging therapies. Next slide. These are my disclaimers and disclosures. I am very actively involved in clinical research trials and have been involved and am actively involved in many of the trials of compounds that will get discussed. And as Monica mentioned, this talk is sponsored by NLS. Thank you. The goals today are to do an overview of narcolepsy, talk a little bit about incidence, key features, and the diagnosis, available treatments for narcolepsy, and then to focus on the ongoing clinical trial of Mazindal ER for the management of type 1 and type 2 narcolepsy. So narcolepsy is a chronic, manageable neurological disorder characterized by sleep-wake state instability and REM sleep dysregulation that lead to a pentad of symptoms. Excessive daytime sleepiness, which is the hallmark of narcolepsy, hypnagogic and hypnopompic hallucinations, sleep paralysis, cataplexy, and disrupted nighttime sleep. I think it's worth mentioning that when I trained, we talked about a tetrad of symptoms. But disrupted nighttime sleep over the last 20 years, it's become quite clear that the disruption of nighttime sleep in narcolepsy is a key feature and has to do with the underlying pathophysiology. In normal function, REM sleep should only occur when we're asleep and only when we're asleep at night. So REM is captured within sleep. And in narcolepsy, REM and its features of paralysis and dreaming escape from the control of nocturnal sleep and can occur throughout the 24-hour day and can intrude into wakefulness. Cataplexy is the abrupt triggering of the paralysis of REM sleep by emotion when we're wide awake. Next slide. There are multiple neurotransmitters involved in wakefulness. There are the monoamines, dopamine, serotonin, norepinephrine, as well as histamine, and then stabilizing alertness is orexin. The concept of a balance between sleep and wakefulness in a dynamic way was proposed by Dr. Al Saper up at Harvard in 2001. And there are regions of the brain responsible for promoting sleep, particularly the ventrolateral preoptic area, producing GABA for sleep. And on the right side of the screen, the monoamines, multiple brain regions producing wakefulness. But across the top of this diagram in lavender, you see that orexin is required to stabilize wakefulness. So you can become awake, but you need something to help you stay awake. And that is thought to be a major purpose of orexin. And some people now believe that histamine may also help stabilize wakefulness once we get into the awake state. Next slide. This is a diagram showing that state instability and the difficulty staying awake or asleep in narcolepsy. So the top sleep hypnogram has wakefulness at the top of the bar where the arrow is, and this patient is awake all afternoon, right up to just before midnight. They then fall asleep and cycle into deep slow wave sleep, which should predominantly be in the first third of the night. And then each of these lavender areas are episodes of rapid eye movement sleep that typically cycle in a regimented fashion every hour and a half to 2 hours. This patient wakes up just before 8 and has solid wakefulness for the remainder of the day. Below is an example of a sleep hypnogram in an individual with narcolepsy, where we can see the patient dip into deep slow wave sleep, awake again, and then the sleep period beginning right with REM sleep in a lavender bar, just right at the very beginning of sleep rather than 90 to 120 minutes thereafter. And then up and down and up and down and up and down. Many, many more awakenings during the sleep period. And then after 8 a.m., we can see that from 8 a.m. till 6 p.m. on the right side of the screen, this patient has multiple episodes of REM and actually drops into deep slow wave sleep as well. This is what I'm talking about when we refer to state instability. And it is these orexigenic neurons from the hypothalamus in green here on this diagram that support the monoaminergic nuclei to continue to produce wakefulness once we move into that wakeful state. And those nuclei then connect to all of our neurons throughout our heads to be sure that we stay wide awake when we need to. Next slide. In narcolepsy with cataplexy, there is good evidence that there is a loss of these orexin-producing neurons in the hypothalamus. That loss may be due to an autoimmune trigger and response to environmental factors, infectious factors, and there may be genetic factors that play into how susceptible any one individual might be. Loss of these neurons is not necessarily seen in type 2 narcolepsy. Next slide. Narcolepsy has an incidence of 1 in 2,000, which means about 200,000 individuals here in the US alone have narcolepsy, with a peak age of onset from the mid-teens through the 20s, but a range that can go as young as age 5 and up into the 40s. The diagnosis of narcolepsy requires a high index of suspicion. I always teach my medical students at GW in the hour that I get to teach them everything they want to know about sleep and wakefulness, that if they wait to see a sleep attack right in front of them or an episode of cataplexy, they will probably never make a diagnosis of narcolepsy. We need a really thorough medical history, psychiatric history, and also focusing on a history of head trauma with sustained loss of consciousness, which can cause post-traumatic narcolepsy, serious childhood illnesses with days and days of sustained high fevers, and very interesting, after the H1N1 influenza epidemic of 2008-2009, there was an abrupt increase in the incidence of new episodes, new diagnoses of narcolepsy, suggesting that that particular virus cross-reacted in an autoimmune fashion with those orexin receptors and neurons. Family history is important, although we don't tend to see clear-cut autosomal dominant or recessive genetics, but there's often a family history of other members of the family. Some may have just sleepiness, some may have episodes of sleep paralysis more than the general population, and exploring the family history becomes quite important. And occasionally we honestly see a family member and do make a diagnosis of narcolepsy in them as well. A careful differential diagnosis is important. So what I'm talking about here is what else can make you look like you have narcolepsy and not be narcolepsy? So anything that interferes with good quality, consistent sleep from night to night has the potential to leave us sleepy. Patients with circadian rhythm disorders who go to bed at 3 o'clock in the morning and have to wake up for work by 7 during the week and are extremely sleep deprived during the week, sleep in very late on the weekend. Night owls of the world sometimes get so cumulatively sleep restricted that if we don't stabilize them first before doing diagnostic studies, they can test out and look like they have narcolepsy on the testing that we do. So, and there are also metabolic factors. Thyroid dysfunction can leave people tired. And so a good thorough look at other possible causes is important. And then the patient comes to the sleep laboratory for an overnight sleep study, followed by a daytime multiple sleep latency test. And on the next slide, I'm going to show you a little bit about what that looks like. On the top diagram is a true sleep hypnogram from a patient with narcolepsy. And what's striking about this, I don't know if you can see the time markers across the bottom, but the patient was in bed at 11:27, fell asleep within 2 or 3 minutes. So very rapid sleep onset, especially in a lab with a lot of wires on, and cycled very early on into REM sleep. Within 5 minutes of falling asleep, you can see circled there in the top left, this patient cycled into REM sleep. And that is a hallmark of narcolepsy, the early onset of REM sleep at night. And when REM sleep occurs within 15 minutes of sleep onset, it can count as equivalent to a REM intrusion into the daytime naps. Below this is the nap study. So the patient woke up a little after 8 in the morning, and at 9:38 began a series of 5 naps at 2-hour intervals, where this individual was given an opportunity to take a nap. And what we see in the latency to sleep column, just to the left of the column with the red circle, is that this patient fell asleep on each of these naps within 1.5 to 5.5 minutes of us saying, okay, close your eyes, it's okay to go to sleep if you wish. And the average time to fall asleep here was 2.9 minutes. The criterion for a diagnosis of narcolepsy is that the patient fall asleep on a nap study done in the setting of adequate sleep within 8 minutes of lights out on average over 4 to 5 naps. We do the 5th nap if there aren't 2 REM intrusions by the time we get to the time to do the 5th nap. This patient had 5 full naps and cycled into REM sleep, as you can see in the circled column, in each and every one of these naps. In type 1 narcolepsy, the patient would have these features with at least 2 REM intrusions and an average sleep latency less than or equal to 8 minutes. And in type 1 narcolepsy, there would be a history of cataplexy as well. With type 2 narcolepsy, no history of cataplexy. Next slide. The goals of treatment are to improve wakefulness, reduce cataplexy attacks, to treat the disturbed nocturnal sleep, and when present and bothersome, to try to address the sleep paralysis and the sleep-related hallucinations, and also extremely important to address the health-related quality of life issues surrounding the difficulties that patients with narcolepsy may have with employment situations, maintaining jobs, psychosocial interactions, and home life. Next slide. Sleep hygiene is extremely important. My patients are very, very sleepy. If they stay up late, sometimes they're not a whole lot more sleepy the next day, but I always think it's extremely important to emphasize the need for adequate sleep at night, which for adults is 7 to 9 hours. And when you short shrift yourself on adequate sleep at night, you are less likely to get the full benefit from any medications that you're taking to improve your daytime alertness. So I always say fill the pot with adequate sleep on a very consistent basis from night to night. Timed naps can be very effective in improving alertness for up to 3 to 4 hours after a short 10 to 20 minute nap in many of our patients. One of the plus sides of this pandemic is that patients have been teleworking and can more flexibly take a 15-minute nap in the mid-morning and the mid-afternoon to improve the quality of alertness. Of course, there are a lot of other negative sides. Wake-promoting agents and stimulants are prescribed to improve alertness, anti-cataplectic agents, and then once again, to focus on any needs the patient may have in terms of psychosocial support. Next slide. So the available treatment agents for narcolepsy include the wake-promoting agents, modafinil, armodafinil, solriamfetol, and pitolisant. The last 2 are the most recent added to our armamentarium of medications available. The traditional stimulants are still used often to tweak alertness at the end of the day for short periods of time or the mornings. And these include the methylphenidate and the dexedrine derivatives. and sodium and low sodium oxybate. When I began to practice neurology in the dark ages of 1981, we only had traditional stimulants and we didn't have any long-acting formulations of them. And it was very challenging to treat people effectively and comfortably. Next slide. Treatments for cataplexy include sodium and low sodium oxybate. So you'll notice that the oxybates are FDA approved for the treatment of sleepiness in cataplexy, sleepiness in narcolepsy and cataplexy. The antidepressants, both the traditional tricyclics as well as the SSRIs, have positive action to manage cataplexy. Pitolisant is another drug that is FDA approved for the management of sleepiness and cataplexy in narcolepsy. And for cataplexy, we have a behavioral treatment that we don't prescribe, but that patients often put in play themselves, which is a constriction of the range of emotion, where patients will let themselves go in terms of letting go and taking a good belly laugh when something is funny or getting upset about something. And they'll clamp their emotional range, particularly when out in public, to avoid an embarrassing episode of cataplexy. And this is an unfortunate way to have to manage the problem. Next. Narcolepsy is a rare disease with a significant unmet need. This is an interesting survey that was done called the National No Narcolepsy Survey. And 12% of patients thought that their narcolepsy symptoms were completely or mostly under control, only 12%. 93% expressed frustration with the current treatment options. 94% stated that new treatment options are needed. So there were many treatment options in these past two slides, but people still feel that they are not being normalized across their daytime hours by the available treatments. Next. The investigational agents that are out there now for narcolepsy are quite numerous. So we have a burst of very interesting activity in the research realm for treatments for narcolepsy. On the top left, FT218 is a once nightly formulation of sodium oxybate from Avadel. This is at the FDA awaiting an approval, we hope. Axsome Pharmaceuticals has AXS-12, which is under clinical trials across the US now. It's a multi-center trial of reboxetine. This is a selective norepinephrine reuptake inhibitor. It is marketed in multiple European and Asian countries for depression and is being studied for cataplexy in narcolepsy here in the US, and that trial is open. Subin Life Sciences has an ongoing trial of a histamine 3 receptor inverse agonist to manage both type 1 or type 2 narcolepsy. And Theranexis has an interesting study of two drugs that are on the market right now, FDA approved modafinil, FDA approved for the treatment of narcolepsy, but in combination with flecainide, which is a cardiac anti-arrhythmia medication. And the two together seem to have a synergistic effect. And then to the right in the white box, we have agents that target the orexin receptor alone or as well. So Takeda 994 was a study of an orexin 2 receptor agonist that's been terminated and is not ongoing at this time. And Mazindal ER from NLS Pharmaceutics, which has a dual mechanism of action. Next slide. So the novel mechanism of action of Mazindal ER is quite interesting. It both has orexin 2 receptor agonist properties and is a triple reuptake inhibitor of dopamine, norepinephrine, and serotonin. So it hits these alerting pathways in two places. The immediate release formulation of Mazindal was first marketed in the early 1970s FDA approved here in the US for weight control. It was voluntarily taken off of the market. There was a shift in the weight control, the theories of management to different kinds of agents to manage weight. But we have a long history of the safety of this medication. It also has a long history of use to treat narcolepsy on a compassionate use basis in France for over 17 years. And I'll show you some studies that were done from the French data. And Mazendal in its once daily formulation has been studied for ADD and ADHD. Next slide. I'll show you a brief video now emphasizing the mechanism of action.
Narcolepsy is a complex disease involving several biological mechanisms at the brain level. Among the brain systems that normally keep us awake during the day, a special group of neurons produce peptides that are key to this function, orexins. The main form of narcolepsy is associated with the loss of these orexin-producing neurons, resulting in excessive daytime sleepiness and cataplexy, which is a sudden loss of muscle tone triggered by a strong emotion. Currently, there are no approved therapies for narcolepsy designed to target the orexin receptors. With years of research and years of experience, NLS Pharmaceutics is developing Quilliance, Mazendal extended release, a drug candidate in clinical trials designed to demonstrate the benefits of its unique dual mechanism of action. Quilliance has potential to address the root cause of narcolepsy by binding to the orexin 2 receptor, mimicking the action of orexins, thus promoting cataplexy control and wakefulness. At the same time, by inhibiting the reuptake of key monoamines, Mazendal stimulates the other centers involved in sleep-wake regulation.
This diagram just emphasizes that on the right, we can see that Mazendal will block the reuptake, leaving the neurotransmitters, monoamine neurotransmitters in the synapse longer to promote wakefulness, and has that direct partial agonist action at the orexin 2 receptor. Next slide. The regulatory history is actually quite interesting. As I mentioned, it was on the market from FDA approved from 1973 until the early 2000s. This past summer in June, there was an IND, an investigational new drug application submitted to the FDA by NLS, and it was approved in July of 2021, which is a very rapid turnaround time. And I think it reflects the fact that there are many years of safety information on this compound available, at least in its immediate release formulation. There's an ongoing phase 2A trial and a 6-month open label extension study that I will talk to you more about here in a moment. And NLS was granted orphan drug designation for Mazendal, which helps with the regulatory process. Next slide. Immediate release Mazendal was studied in a retrospective chart review sponsored by the French Health Ministry for patients with drug-resistant, treatment-resistant narcolepsy. They identified 139 patients who were treatment refractory to modafinil, methylphenidate, and sodium oxybate. It's a very tough group of patients that they identified and treated with the immediate release formulation of Mazendal, which was available on compassionate use basis in Europe, and saw a 4.2 point improvement in the Epworth Sleepiness score with Mazendal, and a reduction in cataplexy episodes from 4.6 episodes on average prior to Mazendal down to 2. So this has shown a positive risk-benefit ratio of 60% for these drug-resistant patients with hypersomnia, and a positive effect on cataplexy, which is encouraging. Next slide. There's also been a pilot study of Mazendal in a controlled release once daily formulation in children with ADHD. This trial looked at 24 children aged 9 to 12. And I mention it mostly because, one, it's quite interesting, but there was a 90% improvement in the ADHD rating scales, and minimal side effects with mild to moderate appetite suppression as the main thing that was seen. So safety, again, acknowledged, and good attention focusing properties for sure. Next slide. This is a double-blind, placebo-controlled phase 2 study of the Mazendal controlled release formulation, this time in adults with ADHD. This involved a bigger group, 85 participants, age 18 to 65. 75 completed the 6-week trial, which was a 1-to-1 randomization between placebo and Mazendal. And there were, again, improvements in the ADHD rating scales, and good safety and tolerability, and a robust effect on the ADHD symptoms. And side effects were mild, dry mouth, nausea, with minimal to no effect on blood pressure and heart rate. Next slide. And this study that's ongoing here in the US now, which is a multi-center trial, which is one that we are participating in as well, is a 4-week double-blind placebo-controlled trial of Mazendal in an extended release formulation of 3 milligrams compared to placebo with a 1-to-1 ratio. They are recruiting 60 patients aged 18 to 65 with both type 1 or type 2 narcolepsy. And the study has a main primary endpoint at looking at improvement in that 8-point Epworth sleepiness scale, documenting how likely you are to fall asleep in key activities. And secondary endpoints include the patient's impression of improvement, as well as the reduction in weekly cataplexy attacks. And this study, this double-blind placebo-controlled study, where if you enroll, you may have a 50% chance of having placebo, is then followed by a 6-month open label study, which means that patients who do participate in this and become subjects in this trial will get the Mazendal 3 milligram extended release for that 6-month period of time. Next slide. Why study Mazendal extended release? Well, we tried to emphasize the unmet need for more treatment options in narcolepsy. We have this very novel dual mechanism of action with partial orexin 2 receptor agonism and activating the monoaminergic system, as well as address evidence that this compound can treat both the sleepiness and the cataplexy in narcolepsy. We have a very long history of the compound in its immediate release being available on the US market with good safety and tolerability features, which is very nice to have for anyone volunteering to participate in the study, and for those of us running the studies, and a positive experience with off-label usage. When it was here on the market, for weight loss, it was scheduled as a Schedule 4 substance and with low potential for abuse or misuse. And we would expect that would be similar if the trials are positive that we complete. Next slide. So Mazendal ER is in a phase 2A trial enrolling in the US adult patients with type 1 and type 2 narcolepsy. So once a day dosing in the morning with an open label extension. And on your slide there is a website where you can read a lot more about it at polaris.nlspharma.com.